So good morning everybody, and I'm delighted to be here at the Joint Research Network, which is a collaboration between UCD and the National Maternity Hospital, where we're looking at midwifery projects that are very relevant to us and researching various topics. So it's a great opportunity now with the publication of the National Maternity Strategy to review the strategy and to think about our work as midwives and what areas for future research might particularly be pertinent in terms of what's evolving as the strategy for the future of maternity services. So I was very privileged to be on the strategy group, which was formed by the Minister last April. So we had 9 meetings in total over a period of 9-10 months, a very long pregnancy. The strategy was evolved because of unfortunate death of Savita Halappanavar in Galway and the subsequent HICWA inquiry, which happened in 2012. And it was very clear from that inquiry that there was no overarching strategy for maternity services for the country. And HICWA were very critical of the Department of Health for that lack of direction. So it was an imperative for the Minister for Health to develop the strategy. That was, I suppose the steering group was put together in March, April 2015, and 31 members. You can see there was a very wide representation across health services and consumer representation. So the Department of Health, HSE, various doctors, midwives, allied health professionals, service users, academics, and people from the State Claims Agency. We had, as I say, 9 meetings. There was a very large public consultation with 1,325 submissions received, and that was probably the largest submission response ever to a call for submissions from the Department of Health, I believe. 800 of them were from individual women, and 500 approximately were from service groups and organisations and associations and hospitals. And it was a very, I suppose, interesting process to get consensus from the wide-ranging representatives at the group as to what people could live with in terms of a maternity strategy. So this was the vision. Women and babies have access to safe, high-quality care in a setting that's most appropriate to their needs. Women and families are placed at the centre of all services and are treated with dignity, respect and compassion. Parents are supported before, during and after pregnancy to allow them to give their child the best possible start in life. And that was our vision that we thrashed out over several meetings. And the key priorities, and I've just highlighted the 4 priorities there in bullets. The strategy aims to improve health and safety and quality in general and standardised care across the units. And I think that's the biggest thing that most of us know, is that standardised care is not always seen across the services. And the strategy recommends a health and well-being approach to give babies the best start in life and to improve women's health generally. And that we're ensuring that women's safe choice is facilitated to the greatest extent possible, and improving staffing levels and facilities in maternity units and in the community. So I think the safe choice was again, out of that slide, I would say that was probably the hottest topic throughout all of the 9-10 meetings. A lot of discussion about what is safe and what does choice mean. That's just a context of the births by mode of delivery in Ireland, and you can see that the instrumental and caesarean section rates, not so much instrumental rates, but the caesarean section rates are rising incrementally. And you can see that's over a 10-year period, or that's actually over 13 years, is it? In total, since 2016, we can see that the rise is now over 30% almost nationally. So it's quite a stark figure when you contrast it to what we would aspire to in terms of normality and achieving less interventions. So this slide here refers to models of care, and again this was hotly debated and discussed over the period of the strategy development. So the current service, we all could agree, is predominantly hospital-based and consultant-led, with very little community services across the country. The strategy eventually has recommended a move to integrated team-based approach, which would be based on safety and women's needs, and that every woman would have a named lead professional. And that will be a very interesting concept to try and implement across our very busy service, but a very important principle to put in there. And the language of consultant-led and midwifery-led was not included, as they're very profession-centric, as opposed to being about women's needs. And the patient safety principles underpin care delivered at the lowest level of complexity, yet can adapt to complex and specialist care where needed. And talking about care pathways, again, this probably took us 3 or 4 meetings before we even got to some form of consensus, but very interesting discussions. Instead of using the midwifery-led, consultant-led and the various discussions like that, we eventually agreed on a formula of wording. So supported care, assisted care and specialised care. And again, that's not something that everybody could live with, but eventually everybody could sign off on that in the document, which was really good. So you can see that the supported care refers to midwifery care really, in alongside birth centres and in some cases home birth. Assisted care refers to somebody who might have normal risk for certain elements of a pregnancy, but may have other complex needs for requiring the social worker, or complex physiotherapy needs, or various other requirements to support her in pregnancy. And then the specialised care is referring to the very obvious high-risk group that we know are present in and growing in our hospitals. And they would deliver in the conventional labour ward, or what we're calling a specialised birth centre. And I suppose the principle we put in there was that all pathways should support normalisation of childbirth, and the patient safety is the overriding principle. And intrapartum guidelines will be developed to the National Committee for Clinical Excellence. So this was really based on the care pathway for critically ill women, and it's, I suppose, based on the principle of having an IMUSE, so that the normal, straightforward woman who's progressing well through pregnancy will progress through the normal pathway, but that the woman who develops problems, who was at the early stages normal and develops problems, might be picked up very quickly by the midwives and referred on to the appropriate pathway. So you can see the blue box there refers to the normal, detecting clinical deterioration early, and then responses varying depending on the level of problems that the woman develops. So the multidisciplinary care components will regard, if she deteriorates, that there would be a very quick response to that. And then she may be referred to a level 2 centre, which would be the delivery suite in a maternity hospital. And she may require high dependency critical care in a general hospital, or obviously if the hospital is co-located in their adult facility. And then obviously level 3 refers to the adult facility where she would be in intensive care. And so that's describing the pathway for the woman who becomes critically ill. There was a long discussion about governance, and the development of maternity clinical networks is going to be very important in this. So as you all know, we're part of our Ireland East group, and our colleagues are Mullingar, Wexford and Kilkenny. So it's envisaged that the maternity services will be under one clinical framework, and that the clinical governance systems would ensure that there are audit meetings, quality assurance, and that it would be based on the idea of having one single governance framework across geographical sites, and that risk stratification of women would occur, and that the woman would attend a tertiary centre if she's very complex and high risk, and that there would be rotation of staff across sites, and that would include doctors and midwives and other staff, to ensure that they retain their clinical expertise in caring for high risk women, and also addressing normality as well. So that one will be very difficult probably in the short term to envisage, but I do think that as the groups emerge and are strengthened, that will probably be something we will see a lot more of, that there will be a rotation across sites. And in the document, the chair has written that with the sharing of expertise, the smaller units' operational resilience can be strengthened. And I think that was very clear from reports into Portlaoise, that really there hasn't been that resilience for expertise for a smaller unit that wasn't dealing with complex women and that wasn't able to provide that complex care. So the leadership of these networks will be very important, obviously, and the master in the Dublin setting, or the clinical network manager in each hospital group, so there will be a network manager in each of the 6 hospital groups, that there will be corporate clinical governance and network budget will rest with that person, that they will be accountable to the group CEO and the hospital board, or the group board I should say, and the principle that the person who holds a responsibility and or accountability must have the authority, the tools and the capabilities and sustained supports they need to carry out their responsibilities. And I think that's something that you can often see in our service at the moment, that people have the accountability but don't necessarily have the responsibility to recruit, and that can lead to big problems for us in terms of having the right workforce in place to meet our needs. And I think the other issue there that's very clear is that the reporting lines for all staff must be clear and unambiguous. There's a lot in the document about workforce planning, and there is a plan to set up a cross-sectoral working group in this coming year, hopefully, in the Department of Health to look at the workforce planning needs of cross-maternity services and indeed across the health services. But it's very clear at the moment we have quite a lot of deficits. There's at least 100 obstetricians short, and that's been identified by the OBS and Gynae programme. There are 148 midwives short this year, and that's identified across the country within the National Birth Rate Plus report. There's a shortage of neonatologists. There's a shortage of 50 neonatal intensive care nurses, and that's been identified through the paediatric and neonatal programme. We have a shortage of anaesthetists, perinatal psychiatrists. There's only 3 nationally in the country, and those 3 are in the Dublin maternity hospitals. So there's a huge deficit there in terms of mental health. We are about to appoint the first advanced nurse practitioner in mental health, in perinatal mental health in National Maternity Hospital, and she will be setting a very important trend in the country for that post, because there is such a deficit in the support for women who are undergoing mental health difficulties after pregnancy or during pregnancy. And the other shortage, we all recognise there's a shortage across other allied health professionals, physiotherapists, dietitians, etc., social workers. So I suppose there's a whole lot more in the document. There's 177 pages, but I just wanted to synopsise it very quickly for you in those few slides. But delivering the strategy is going to be a very, very important piece of work. It's envisaged that there will be a national women and infants programme within the HSE, and there is a move at the moment to appoint a clinical director, a programme manager and a director of midwifery to that group, and they will be employed at a national level to deliver on this strategy. The programme will develop, monitor and develop and monitor implementation plans for the strategy under the headings of health and wellbeing, safety and quality, models of care and governance. So there'll be quite a lot of streams of work there. They will be developing the KPIs to see that this happens, and they'll be reporting annually to the Minister on the progress. And as I say, there's 77 actions identified, so it's a huge piece of work. The challenges in implementing it. Well, all of us in the room here are very experienced in the health services at the moment, and we don't underestimate the challenges. Setting up the programme office itself is being difficult with attracting the calibre of people who need to do this. Reconfiguring the current services, that's written in small letters there, but it's going to be probably the biggest of the challenges. Working within the hospital group structure, again, that's a challenge because of the distance between the hospitals, the lack of resources at the moment, and the lack of legislation at the moment to support the groups. That's all being, I suppose, going to make it difficult at the moment to make these changes happen. The levels of national investment needed in the current infrastructures is not, again, without its challenges. There's no actual cost involved, but you're looking at hundreds of millions. The National Maternity Hospital move to St Vincent's will be at least 150 million, if not 200 million as in itself, never mind the move of the Coombe and the Rotunda to Blanchardstown. So then that doesn't account for all the other investment that's going to be needed in the sites, the 15 other sites around the country. Human resources, again, we need a lot more midwives, a lot more obstetricians, a lot more of the various other grades. And retention of midwives and doctors in the service has been widely discussed, and we know that's a difficulty. The whole change management piece will be extremely interesting. And I suppose meeting expectations of service users and service providers, because there's been a lot of talk about the strategy now and how will that be delivered. And we've raised expectations by doing this public consultation, and there's going to be a lot of demands now to deliver on some of these changes. But in the background then there's the retaining confidence and trust in the maternity services. And we've known for the last 3 to 4 years, since the Galway report in particular, and then the Neary report before that, then we had the Portlaoise report in more recent months, in the last 2 years I should say, in the Boylan report looking into the Portlaoise failures of care. So all of that has led to a decrease in public confidence, and we see that in the way that women at times approach our services and approach the complaints process. They have a lot of concerns. They are expressing concerns about the way their care is managed at times, and that's because there is that lack of trust, unfortunately, within health or within maternity at the moment, and it's within our gift to work towards increasing that trust again. But I just want to finish by maybe putting it into perspective a little bit, and it does depend on whether you're on the boat or on the island. And for me, I think hopefully we're always on that island looking, and we're not on the sinking ship. We're on that boat. It is obviously a challenge, but it does depend. And for me, I suppose, as a director of midwifery, I've been working in the service in this role for 10 years now, 10 years yesterday, which is incredible to me. And a couple of years ago, I had an opportunity to really put my midwifery care into perspective. When I went to Malawi, I had an opportunity to visit Lilongwe. And I just wanted to show you this 2 or 3 pictures. This was a new labour ward in Lilongwe, and the picture on the right here is there. We're very proud of this room. This is a tiny cubicle, but women were delivering in private, at least, in this room, on a plastic sheet, on a relatively, what they were delighted with as a new stretcher. There isn't a sheet. There is a kind of a curtain in the background, but there was blood staining on the curtain, which you can't really see in the photograph. And on the left-hand side there, they were showing me their resuscitator. Now that is a locker with a little light bulb on top of it that didn't work the day we were there because the light bulb had no electricity. On the thing you can see a kidney dish with a few little balls of wool, and they were sterilising that wool in this little thing that I haven't seen since, I've never seen it in practice obviously in Ireland, except when once in St James's we had to boil instruments in a little pot in the 80s when I was a student nurse. But you know, that is the level that they're working at, and their maternal mortality rates are 670 per 100,000, and in Ireland we're about 10 per 100,000. So, you know, when you talk about perspectives, and this is another hospital, we talk about Holles Street, and 25 births a day can be really challenging for us. And this is a hospital in Manila where they have 60 births a day. There were 3 women on each bed. And there's the quote at the bottom of this article I read was, the women don't call out because they know there's no point. Nobody's going to get to them when they're in labour. So I'm not trying to patronise ourselves by saying that we have a good service, but we have a fantastic service in Ireland. And I think really it behoves us as midwives to talk about how excellent our service is, and notwithstanding the challenges of our infrastructure and our small hospitals and our, you know, I suppose the lack of investment. We have an incredible group of midwives working in our hospital, and as we're the midwife leaders, we are sometimes the acrobats, we're the change agents. We have a lot of work to do ourselves as midwives to keep our junior midwives motivated and challenged and staying in the service and realising what a fantastic service they provide. But you know, if there's anybody on that barre rail there that can make it happen, it's us, because we're the people who are able to adapt to every situation and able to bring our service forward and encourage and motivate the junior midwives who are in the service. So thank you very much. I think what we're going to do is, through the Joint Research Network, look at the various streams of work that are happening there and try and make sure that we're pushing some of our research agenda towards those streams of work. And we've got a lot of master's students going to be undertaking their dissertations, and we've a lot of other interested people within the hospital and within the university who are doing various pieces of work, and I think we really need to align them to the national strategy here and ensure that we can work towards improving maternity services. So thank you.